Well, welcome. I'm Janet Gatlin. I'm the Director of Outreach for Rogers Behavioral Health. I'm your moderator for today's webinar on understanding and treating body dysmorphic disorder. Joining me today is Dr. Brenda Bailey, Executive Director of Clinical Services for inpatient and residential levels of care, and Dr. Sanjaya Saxena, attending psychiatrist at Rogers San Diego clinic location. Before we get started, I wanted to give a special shout out to our Rogers Madison location. They're having the first viewing watch party. So hello to the Madison team. We're welcoming you. This is very exciting to have our first in-person watch viewing party. And before we get started for the webinar, I wanted to give our participants a quick overview of the format that will be happening today. The webinar is scheduled for 90 minutes. You will receive CE credits. You must be logged into the webinar the entire time. There was no need to check in. You already checked in as you're logging in. The attendance will be tracked via Zoom login records. A PDF of the PowerPoint slides and a list of references will be available immediately after the program via email with a link to your personal dashboard on cego.com. In addition to the recording of the webinar will be published on the resource tab section of Rogers BH and our website within a day or so of this room watching. Our speakers today are planning on presenting a 70 to 75 minute presentation. Following the presentation, I will facilitate a Q&A. You will note that we have deactivated our chat feature. We have found it to be somewhat distracting to our presenters and other participants. If you would like to ask our speaker a question, please use the Q&A button to message me. It will be at the bottom of your screen. You simply click the Q&A button at the Zoom taskbar. I will review all questions submitted, and then the presenters will address the Q&A during the questions of the Q&A portion. Finally, we have enabled the closed captioning for this portion. At the bottom of your screen, there will be a live transcription button from that menu. You can click on show subtitles to view the audio of the text. If you'd like to disable this, just all you have to do is simply click on the hide the subtitles from the live transcription menu. Now I'm going to turn it over to Dr. Bailey to start the presentation.
So we just want to disclose that we don't have any disclosures that we need to make for this presentation, myself or Dr. Saxena. These are some of the learning objectives that we've described for the presentation. So we're hoping that you'll be able to describe at least 4 components of the DSM-5 diagnostic criteria for BDD and potential differential diagnosis, apply 3 components of the conceptual CBT model for BDD, and describe 3 medications found to be effective for BDD. These are the things we'll be covering, and hopefully you all will get what you need to out of this presentation. I won't go over this all specifically, but just to keep you guided through the presentation and what will be covered. And then I believe Dr. Saxena is going to do the overview of body dysmorphic disorder.
Thank you very much, Dr. Bailey, and thank you to Janet and Ruth for putting this program together. Welcome to you all. So I think, we picked this topic of body dysmorphic disorder because from our clinical experience, we know that it's a highly under-recognized area that a lot of clinicians really don't get much training in. And the fact is that all of you have probably seen a lot of patients who had BDD, not necessarily aware that they had BDD or able to treat it. So I think this is it's an important one because it's a disorder that, as you'll see, is quite common and also produces a great deal of morbidity, mortality, disability, and functional impairment. So let's start with some basic definitions and the diagnostic criteria. Body dysmorphic disorder involves a preoccupation with one or more perceived defects or flaws in physical appearance that may not be observable to others or appear slight to others. Even if there is a physical defect or flaw in someone's appearance that other people can notice, you're making a clinical judgment that the person's level of distress is excessive regarding that. At some point during the course of the disorder, whoops, go back again. Okay, there we go. Thanks. At some point during the course of the disorder, the patient performs repetitive behaviors. Virtually all patients with BDD have repetitive behaviors or compulsions at some point during the course of their illness, and most of them have it most of the time. These can include things like repeatedly checking their appearance in the mirror, excessive grooming behaviors, skin picking, especially at acne or other perceived flaws or bumps on the skin, seeking reassurance, and then covert or mental compulsions that can include comparing one's appearance to that of others. Could be things like researching cosmetic surgeries or plastic surgery options, and then, of course, a great deal of avoidance. Next slide, please. You determine clinically that the preoccupation and repetitive behaviors are causing clinically significant distress or impairment in social, occupational, or important areas of functioning. And the functional impairment seen in patients with OCD is at least as severe, if not more severe, than in most patients with OCD, especially in the social realm, but it could be in any different area of functioning. And you have to make sure that the symptoms you're seeing are not better explained purely by eating disorder symptoms, that is, concerns with body fat or weight or overall body size in an individual whose other symptoms meet diagnostic criteria for an eating disorder. Now, this is complicated because many patients may have comorbid anorexia nervosa or bulimia nervosa and BDD. So it's important as a clinician to learn how to distinguish between those and to treat them individually, because there's some overlap in their treatment, but there are also some major differences. There are also some subtypes of BDD to be aware of, and one of them is called muscle dysmorphia. People have also called this bigorexia. It's a preoccupation that one's body build is too small or insufficiently muscular. This is seen more often in men than women, but it is sometimes seen in women as well, and particularly within the community of bodybuilders, weightlifters, fitness experts, and in veterans, actually, in active duty military populations. Next slide, please. You can also specify the degree of insight. And as we go through this presentation, we're going to be talking quite a bit about insight because it's a major hallmark of OCD and one of the ways in which a hallmark of BDD, and one of the major ways it differs from OCD. One change that occurred between the DSM-4 and revisions and then the DSM-5 that came out almost 10 years ago now are that many of the disorders, and all of them that are in the OCD spectrum or OCD-related disorders category or chapter, have insight specifiers, because it is recognized that patients vary from within their own course and then across different patients vary in terms of the level of insight. And so you can indicate that degree of insight that the patient is displaying at any one time at any session. With good or fair insight means that they recognize that they have BDD and that their beliefs about their appearance or perceived ugliness, perceived flaws, and so on are probably not true, or at least that they may or may not be true. And then the next is poor insight. The person thinks that their beliefs about their appearance are probably true, and they may be ambivalent or doubtful about the BDD diagnosis. And then lastly, absent insight. We can call this delusional level BDD, BDD with psychotic features. You can use different terms, but really what this refers to is that the person is completely convinced that their perception and beliefs about their appearance are accurate, right? So they're absolutely convinced that they're ugly, flawed, deformed, repulsive. There may be a whole set of different beliefs and attitudes and emotional responses to this. Next slide, please. So in the clinical presentation of BDD, we're looking, of course, for the symptoms that fit the diagnostic criteria, but then there are other things too that are associated. So appearance obsessions are, of course, one of the main hallmarks, right? Usually about multiple body parts. Some studies of BDD patients show that patients through their course of their disorder may have concerns on average about anywhere from 5 to 6 different body parts, and it can change from time to time. So some patients will have, concerns about one aspect of their face earlier in their life, and then later on it's some different part of their body. And then at other times it might be multiple parts of their body. The most common body parts involved and focused on in the preoccupation would include the skin, and this includes acne, but also other things related to the skin, the face, including the shape of the face, the attractiveness of the face, and so on, hair, nose, stomach, teeth, breasts, genitalia, and muscles. And one of the other big differences from OCD is the emotional response. So it's not just anxiety and distress and fear. It may often be intense shame, disgust, and depression. Close that here. Next slide, please. So here's an example of a picture drawn by a person who had BDD when asked to describe her own appearance and how she perceived her own appearance when she looked in the mirror. And it's kind of hard to see here, but I'll sort of read out what it says. This is her BDD analysis. She's got little arrows pointing to all different parts of her face. Short, fat, rectangle nose. Small, narrow head, small brain illustrates lack of intelligence. Well-groomed eyebrows, although unsuited to the face shape. Droopy, sad eyes with long, straight lashes. Ugly, big, fleshy eyelids. Droopy skin around the mouth. Skin is too light and blotchy. Long, narrow underbite jaw. Pointy witch's chin. Head so small, it makes my neck look fat. Face is long and everything is lopsided. Skin hangs on small face. Dark circles give a tired, sad look, and so on. And so what you can see here is that not only is there a distortion of the person's visual perception of themselves, but there's also this huge negative emotional overlay. Right, and those two things relate to one another, and we get into, how the cognitive behavioral model of BDD develops, and the relationship between the negative emotions and negative appraisals and the actual perceptual distortions, and there's a complex interaction there. Next slide. So poor insight, as we mentioned, this is one of the differences between BDD and OCD. About 70% of patients with BDD have ideas of reference. That is, ideas that something ambiguous in the external environment really relates to them. So, for example, they see someone across the room turning their head, and they think, oh, that person is turning their head away because they saw me and they were repulsed and couldn't stand to look at me, right? And these can move even into full-blown delusions of reference. Anywhere, depending on the study and the particular clinical population you're looking at, somewhere around 1/3 to 50% of people with BDD are fully delusional at the time, but this varies, and it can vary within the patient. So the level of insight and the level of delusionality also varies with the overall severity of BDD, and it varies even with the degree of psychoeducation and understanding about the nature of the disorder they have. So it is not as fixed as it is in some of the primary psychotic disorders, such as schizophrenia, schizoaffective disorder. Poor insight in people with BDD correlates with higher negative affect, lower positive affect, lower self-esteem. Across time, self-esteem and insight influence one another reciprocally, with comparatively stronger effects for prediction of poor insight by previously lower self-esteem. And as I mentioned, overall BDD symptom severity also predicts worsened insight. Next slide, please. So in addition to the appearance-related concerns, the focus on different body parts, the level of insight into that, there are also the compulsions, the repetitive behaviors. And these are the behaviors that probably are a little bit more similar to what you see in people with OCD. Grooming behaviors, mirror checking, skin picking, camouflaging, comparing your own body to others, and so on. 70% of people with BDD have cosmetic, dermatological, or plastic surgery. and the vast majority are dissatisfied with its results. So plastic surgery and dermatology practices are filled with people with BDD. And the plastic surgeons and dermatologists and other clinicians in those specialties have sort of varying levels of understanding of BDD. And unfortunately, they run into trouble because the patients are pressuring them to get procedures done, skin procedures, surgeries, and so on. And then it usually doesn't go well. And then sometimes they get sued. In general, cosmetic surgery, dermatological, and plastic surgery are not indicated for patients with BDD. And frequently, there are things that a clinician should try to get the patient to avoid and not do, because it's really just another compulsion that doesn't end up serving its purpose. And lastly, severe avoidance. And avoidance, again, is one of the major hallmarks of BDD. Avoidance of school, work, social events, anything that would involve people seeing their appearance. This can include avoidance of intimacy. There are a lot of BDD patients who don't want to date, have never asked anybody out, and are very, very afraid to be in any sort of intimate relationship because they don't want a partner to see that part of their body that they're concerned about or think is ugly. Most BDD patients in clinical settings are unmarried. So there's severe functional impairment across a number of different domains and very low quality of life. Next slide, please. So how common is this? Well, it turns out that BDD is more common than OCD. So the point prevalence, the single point prevalence in the community is about 1.9%, contrasted with about 1.2 or 1.4% for OCD. The overall lifetime prevalence is somewhat more similar. Both OCD and BDD are roughly found in about 2 to 3% lifetime prevalence, depending on the study you're looking at. The prevalence of OCD changes with age. So you have, pretty prominent 2% in adolescents, 4% in populations between 18 and 44, but less than that, 1.4% in people over 45. So the mean age of onset is around 16, and the modal age, so the most common age of onset, is actually around 12 or 13, but there's a broad range. So the mean is actually higher because some people may have onset in their 20s or 30s even. About 2/3 of people with BDD have their onset by age 18. So that is somewhat similar to OCD, where the bulk of people will have a relatively early onset. And it usually begins gradually. So you get subclinical symptoms starting first around age 12 or 13, and then they build. Sometimes there'll be stressful events that will propel the symptoms into a much more florid and disabling state at some point. But there have been case reports and series of cases of BDD that start around age 7 or 8 even. And then a few that were later in life, perhaps after menopause, or a few in the postpartum setting. And the prevalence, as you can imagine, is much higher in clinical settings. So 10 to 12% of psychiatric outpatients have been found to have BDD. Very high percentage, 10%, 15% in plastic surgery patients and dermatological settings. The male-female ratio is about 1-to-1. So this is another similarity with OCD, and different from major depression and most of the other anxiety disorders. And the course, unfortunately, is quite continuous. So continuous in 85%. There have been follow-up studies looking, let's say, up to 4 years later after initial evaluation, and only about 20% of patients were in full remission, and maybe only even 35% were in partial remission. So the majority of patients, unfortunately, continue to have symptoms. Now, obviously, that's going to be largely determined by the effectiveness of their treatment. And in practice, most people with BDD don't ever get either diagnosed or properly treated for their BDD. It's another reason for this presentation. Next slide. All right, so suicidality is something that we really want to do highlight, and because it is a major factor in BDD, and again, another difference from OCD. 78% of people with BDD will have suicidal ideation at some point in their lives. In any 1 year, over half have suicidal ideation. 25 to 30% will make a suicide attempt, at least one, in their lifetime. 2.6% of patients per year in a long-term follow-up, and about 0.3% per year die by suicide. So that's much greater than what you see in OCD or virtually any of the other anxiety disorders. It's more similar to what you see in severe mood disorders. Genetic factors account for a lot of that covariance between BDD symptom severity and suicidality. Those are closely related. Other risk factors for suicidality and suicide attempts in people with BDD include their other diagnoses. So if they have comorbid bipolar disorder, major depression, PTSD, substance use problems, severe personality disorders, they're at greater risk. But even if you control for those, BDD symptom severity is an independent predictor of suicidality and suicide attempts. So just by itself. And of course, there's a great deal of depression. Depression mediates the relationship between BDD and the intent to harm oneself, but it doesn't create the initial suicidal ideation by itself. That comes oftentimes directly from the severity of BDD. Next slide. And so that brings up comorbid disorders, right? The big one is major depression. More than 3/4 of people with BDD have had, will have, or currently do have a major depressive episode. Very high lifetime prevalence. OCD is less common. There is an overlap, so about maybe 1/4 to 1/3 of patients with BDD also have comorbid OCD. If you look the other way, maybe about 15-20% of people with OCD also have BDD. So there's some overlap, but they are clearly not fully correlated together. Substance abuse is in much greater prevalence in people with BDD than in OCD, where it's relatively low. Social anxiety disorder, as you can imagine, is very prominent. So 38% lifetime, around 1/3 at any one time. And it can be sometimes difficult to distinguish between social anxiety disorder by itself and what is just purely secondary to appearance concerns in BDD. One way that sort of a trick that helps you discern this is to ask a patient who has a lot of social avoidance, okay, well, what about phone calls, right? Do you have anxiety when you talk with people on the phone? A lot of people with social anxiety do. They'll avoid phone calls. You know, having to make a phone call to someone they don't know is very anxiety provoking. Usually, if it's purely just BDD, they have no problem with the phone call because nobody can see them. If you say, well, okay, but what about video conference, right? Zoom or in person, then there's a great deal of anxiety and distress and avoidance. And that's part of how you can tell whether the avoidance is based mainly on appearance concerns or mainly on kind of traditional social anxiety concerns about, I'm going to put my foot in my mouth, I'll say something stupid, they'll reject me, so on. Eating disorders, as you can imagine, there's a great deal of similarity between BDD and eating disorders, and they're highly prevalent, maybe 1/4 to 1/3 lifetime prevalence. Panic disorder and generalized anxiety disorder are also in high prevalence. Personality disorders, mostly avoidant and dependent, but it can also include some of the cluster B ones like borderline and histrionic. Next slide, please. And how do we develop BDD? If you look at sort of retrospective studies of what people with BDD report in their histories, a larger proportion of them than OCD patients will report a history of physical, sexual, or emotional abuse, usually early in life in childhood, severe maltreatment and major serious neglect in 40%. So that's quite a bit higher. And when asked to identify what they feel led to their development of BDD symptoms, these are the responses you get. Experience of being bullied in childhood, particularly about appearance. So having other people critique your appearance. And sometimes this is within the family. So I've had patients tell me that their BDD started when their brother or sister or mom or dad made harsh comments about their appearance that precipitated a lot of shame, anxiety, feelings of rejection, feelings of inadequacy, and of course the abuse. And these are somewhat different self-reported origins, again, than you see in people with OCD. Next slide, please. Now, how do we assess BDD? I advocate a couple different scales. This first one, the Body Dysmorphic Disorder Questionnaire, or BDDQ, is really fast. It's got 4 questions. The first 3 ask about appearance preoccupations, repetitive behaviors, level of impairment. And the fourth one is a rule out that asks whether all the symptoms are really just related to concern about weight or being fat. And so very, very quickly, if you get positive responses on that 4-question questionnaire, you have a high likelihood that the person does have BDD and it warrants further assessment. The gold standard clinician administered scale for quantifying the severity of BDD is the BDD-Y box, the Yale-Brown Obsessive Compulsive Scale that has been modified for BDD. So this has been well validated for over 30 years, and it's really what's used in most clinical and research settings. And then I advocate another one, the Brown Assessment of Belief Scale, to rate the degree of insight in multiple domains. And I actually recommend having clinicians, track this periodically, every month, every couple of months, because it changes, right? And this is a scale that measures the multidimensional nature of poor insight or variable degrees of insight across many disorders. It's been validated not only for BDD, but also for OCD and for schizophrenia and for eating disorders and even depression with psychotic features. So it's a wide spread scale that has widespread utility. Next slide, please. So initial treatment steps, and obviously Dr. Bailey is about to get into this in much greater detail. Don't try to talk patients out of their beliefs and concerns about their appearance. Start with empathy, start with their personal experience, and acknowledge that you believe that they see what they see. Right. So it's really important to validate that, yes, I get it. When you look in the mirror, you are seeing something that looks really ugly to you or deformed or flawed or repulsive. I understand that. And I understand you're also very, very distressed about that. And it really influences your self-esteem and how you feel about yourself. Let's work with that. Right. And providing psychoeducation about the nature of BDD goes a long way in actually changing people's insight. Meeting other people with BDD, like being in a BDD support group, or just talking with other patients or reading about other people with BDD and realizing, wait a minute, these are all these people that look really attractive to me when I see them, and they all believe that they're ugly. That tells you something, and it helps soften up the degree of delusionality that can be present in many patients. And so you have to, before you can launch into the rest of treatment, you have to assess insight and motivation for treatment and the degree of ambivalence about even acknowledging BDD, willingness to engage in any sort of psychological or psychiatric treatment, as opposed to wanting to go get a surgery done. So their readiness to change. And when that motivation and readiness to change is low, you need to do motivational interviewing and enhancement. And this may take quite some time before you can actually get into the meat of the CBT or the medication treatment. And one thing you want to do is convey that treatment is in fact effective, because that's meaningful. If all these people believe that they were ugly and now after treatment, they no longer believe that they're ugly, and they're no longer distressed by it, that tells you something, right? Did the treatments change their face? No. The treatments changed their perception and how they viewed themselves. And that's really critical, because that's where we're going to focus everything. Next slide.
Great. Thank you, Dr. Saxena. So I'm going to go into more detail about the cognitive behavioral model for BDD and then also the interventions. So what we want to, sorry, my slides aren't moving. What we want to highlight here is that the treatment is very effective. CBT for BDD has been shown to really improve the lives of a lot of people. So there are successful treatments out there. And again, for someone coming in, they may be convinced that the only way to treat their symptoms is to get a surgery of some sort. And so we really want to convey our confidence in the treatment and its effectiveness and share this information with patients so that they understand that this is something that can help them without the costly and interfering surgeries that are out there. The sequence of treatment is important too. We start with assessment just to get an idea of what Dr. Saxena described of, the severity of the symptoms, the level of insight the person has. And then we want to educate the patient about what we are seeing in the diagnosis we're making. This is really important because a person who is not convinced that they have a mental health concern around their appearance is unlikely to buy into treatment and engage in the elements that we're going to ask them to engage in. And then also spending a good deal of time on motivational enhancement is important too, because again, we're missing a lot of people in different settings. And this is not a very common disorder that we hear about. So someone coming in is not going to be typically on board with the psychological intervention. And so we want to really elicit the reasons for why they're coming in and the things that they hope to change outside of, altering their appearance, quality of life, the amount of suffering that they're experiencing. And then we would move into cognitive restructuring of those beliefs, and we'll talk more about that, the perceptual retraining, and then exposure and response prevention and relapse prevention. When you're working with someone with poor insight, really you have to be gentle. You can't be too intense on the outset. That will lead to people just leaving treatment. Already they're coming in probably one foot, one toe dipped into the idea that this may be related to some sort of their psychological well-being versus an actual problem with their appearance. So if you come on too strong and really are pushing exposures and pushing them to be uncomfortable from the beginning, that's likely just going to lead to them dropping out and seeking cosmetic surgeries. And like we've talked about, it's important to not argue with your patients. Really, we're not the judge or jury or the seeker of truth when it comes to what they are seeing or what they're experiencing when they look into the mirror. What we are trying to help with is the amount of suffering they're experiencing from that perception. So when you're talking about the distorted beliefs that a person has, you want to talk about the distress that it causes them versus whether or not they're accurate, especially for someone with very poor insight. You might be pulled to from your patient to get that reassurance, and even it's hard because a lot of times the vast majority, you're not seeing anything wrong with the appearance, and especially to the degree that the person is seeing. So it can feel very easy to say, like, of course you look great, or you look attractive, or there's nothing wrong with your appearance, or even saying, sure, your hair is a little thin, but it's not that bad. That can really damage rapport and lead to a person to feel like they're not really being understood if you're constantly arguing the other side of their appearance concerns. Even also, if you feel like, well, I'll agree just a little bit so that I can get them to, listen to me, that's not going to work either. So we're really not trying to argue with someone. We don't also want to do exposures right off the bat for people who are experiencing very limited insight, because those are going to be far too distressing. And it's a lot of times they're so preoccupied and their beliefs have changed their view so much that they can't see the evidence of an exposure objectively. And usually they're looking for the evidence that's going to reinforce their belief than anything that's going to lead them to come to a different conclusion. So looking at the general framework, I will say if you're really interested in working with individuals with BDD, this book is really going to be exceedingly helpful. It's one of the only manuals out there. I think it is the only manual out there for treating body dysmorphic disorder. And so what we see is that there are body image concerns for people with BDD rather than actual appearance concerns or appearance issues. Appearance is more of an objective view of yourself, whereas body image is how you take what's there and interpret it. And so we're working on that subjective piece. And it's not as much to do with their actual appearance as it is to do with how they are viewing their appearance. And their response to their beliefs about their appearance and their body image is what reinforces that maladaptive interpretation. So the behaviors that they engage in are going to reinforce that belief for them. So speaking more specifically, we'll run through this model. And this is the cognitive behavioral model that you'll see in that book from Wilhelm et al. So first, we have very typical appearance concerns. We all have them. I'd be surprised if there's anybody out there that doesn't have an appearance concern. And so in this example, is my hair falling out? Is my hair too thin? Those kinds of concerns that everybody has. However, someone with body dysmorphic disorder, they'll experience intense triggers for on their beliefs and unpleasant emotions in a response to this. So this will be important when you're doing exposure and response prevention. What comes right before you start to get preoccupied with your image? And so for someone who's afraid that their hair might be falling out or their hair is thinning, hair commercials can be really difficult. Anything on social media can be hard. Showering can be hard because they're washing their hair and they're feeling their hair, and they'll start to wonder, like, okay, is this a bald spot, or is my hair thinning right here? Or they'll be, your hair falls out all the time. You lose over 100 strands of hair a day. So they're like counting the amount. They want to know, like, they're pulling their hair out in the shower to look at it. So that can be difficult. Also styling their hair in the morning. They may spend a lot of time looking for bald spots or looking to see if their hair is thinner. Being around others and comparing themselves to others, that's a very common trigger, is just being around other people. That's why we see a lot of isolation with BDD. Mirrors are notoriously difficult as well. And then anytime they need to like touch their scalp or their hair, can be a trigger for some of these other concerns. And what that does is it activates these interpretations, these very self-defeating interpretations that they make about their appearance. I'm ugly, people won't like me, this is awful, people think I'm gross, I look hideous, I look like I'm, practically bald. So they'll have a lot of really negative interpretations from these events. And then also at the same time having over focus of attention on their concern. So they're very attuned to that area of their body, and they probably spend a lot of time looking at it and checking it and focusing in specifically on that concern. The problem is here, one, the selective attention and over focusing can take a lot of time, and the self-defeating interpretations lead to a lot of unpleasant emotions. And this will say I experience with BDD that it's not usually just like a pure form of anxiety with a little bit of other emotion. It's a lot of unpleasant emotions that they experience from their concerns. So anxiousness being one of them, but there's a lot of sadness and hopelessness, and like Dr. Saxena described, shame and guilt and embarrassment that comes from their interpretations of their appearance or their body image. And then as a result of feeling these unpleasant emotions, they'll try to control them through rituals. And so things like camouflaging, wearing a hat, or researching, trying all these different cosmetic procedures. And that can be broadly defined as, buying things off of the internet that promote hair growth or hair thickness to like actually going and getting actual cosmetic surgery. They could count how much hair they lose in a day and keep track of it so that they know whether or not, because they'll research and know roughly how much hair am I supposed to lose in a day. And if they want to know whether they're losing more or less hair than they should be. They're comparing their hair to others when they're, again, in a situation when they're around other people or on social media or anything like that. They may avoid social events altogether. We do see a lot of isolation of BDD. And then they might do things like avoid pulling their hair back because they're afraid it's going to stretch their hair and leave bald spots. They might have a very particular grooming procedure where, they brush their hair in a very specific way so that they're not losing excessive hair. But you can also ask, like, just what are the things that you avoid and how do you cope with those thoughts that you're experiencing to get more of those rituals from someone. And I'll talk about this later too, but sometimes it's not necessarily whether or not the ritual reduces their unpleasant emotion or their anxiousness, but what was the intent. A lot of times these behaviors won't reduce the emotional experience, but the intent was to reduce their emotional experience. So like researching, I think we've all experienced having a symptom and looking it up with the intent to make ourselves feel better, and we leave the internet feeling like we're gonna die. So the intent was there to feel better, but we didn't actually feel better as a response. Very common rituals are comparing and excessive grooming, camouflaging, checking appearances in mirror or reflective surfaces, getting caught in reflective surfaces. And the comparisons that people make are mostly upward comparisons of I don't look as good as this person, but they can also do downward comparisons too. And a lot of times those upward comparisons are of people who are not a realistic comparison for that person. And then the downward comparison is also someone who's not a realistic comparison. So such as like someone who has had extensive skin damage, or, you know, someone who has a condition that leads to a lot of hair loss. The problem with these behaviors is that they will reinforce these self-defeating interpretations or these negative beliefs about themselves, because they're never really giving themselves a chance to learn anything different when they're camouflaging or avoiding or, you know, engaging in like buying of these hair products and things like that, because they're always trying to fix the concern they have. They're never given the opportunity to learn that, you know, I have this concern, but I can do these things and not, you know, people don't completely reject me, or, you know, I don't get the feedback that I'm gross, or people don't look at me like I'm, you know, some deformed in some way, because they're always hiding behind some of those behaviors. So that's really the problem here, is that these behaviors are reinforcing these beliefs, rather than if they were to not do these behaviors, they'd be able to test some of these beliefs and get some information about whether or not they're as bad as they think they are. These concerns, I think, are very helpful to go over with a patient, not necessarily that they might change over time, but it's important. They think there's a piece of like self-validation that comes from acknowledging that our society really does value certain aspects of beauty, like really thick, curly waves are some, you know, it can be a trend, but sometimes that's really the style. And so if you don't feel like you have that, it can be difficult and lead to some of those general appearance concerns. But again, the way that they engage with those triggers reinforces the underlying beliefs. And there are a lot of psychological factors that Dr. Saxena reviewed of, you know, experiencing bullying or even witnessing bullying, experiencing some social anxiety and very perfectionistic behaviors. Those are things that exist. We can't take away the fact that a person was bullied, but it can help and explain some of the reason why this came about, and it can feel validating for them to discuss that. And then there are biological factors here. I mean, we can, like all of these, like social anxiety, we can address that too. Just in general, through the treatment, we're not going to necessarily change the society's view of what is beauty. But in the biological factor, there are underlying genetics that make someone predisposed to experience certain psychological conditions. They might have a sister or a family member who's very concerned with appearances and, you know, talk about appearances a lot with them, which can be difficult. But the one thing here is, you know, brain chemistry. We can do things, and we have medications that can be successful in helping someone approach treatment and get benefit from treatment as well and reduce symptoms. So some of these interventions, we'll go through them a little bit more. I'm going to talk, even though it's kind of out of order than what we discussed in terms of what's recommended for the order for treatment. I'm going to start with exposure and response prevention. So exposure and response prevention is fairly simple. You expose someone to the triggers, you have them not engage in the rituals or responses that they typically would. And the way that this is helpful is it gets rid of that connection between continuously reinforcing the underlying beliefs that the person experiences. So you're exposing yourself to situations and you're not engaging in behaviors like camouflaging, so that you don't miss the opportunity to disconfirm those self-defeating interpretations. And if you engage in those behaviors, just reinforces the idea that there's something wrong with you. So how we go about this, ritual prevention, in my opinion, is very, very important. It's one of those things that I would want to address prior to putting someone in situations that are going to elicit that anxiety. I want them to demonstrate that they have a good handle on resisting some of their rituals and practicing that before being in those tougher situations. And again, we talked about the intent of the behavior. Were you trying to reduce your anxiety? And if so, if that was the intent, that is something we'd want to monitor. So we start with monitoring. For us at Rogers, we do, banned books, where we have books of behaviors that we don't want people to engage in. They're banned. And we say that, but also it's really important that we acknowledge, for someone who has severe symptoms, just stopping a behavior altogether is unlikely. So we might work to reduce those behaviors at first and delay them. And when you're monitoring your behaviors, you can also identify the situations that are triggering for you. So taking some extra notes of like, oh, wow, I've noticed I started camouflaging when I had to go, to the grocery store. I immediately was like starting to put on my hat and do all those things. So it seems like the grocery store might be one that's really difficult for me. Whereas going to get the mail, I didn't feel the need to put my hat on to do that. And what's nice about just monitoring your behaviors is sometimes there's a reduction just in and of itself. Not biggest reduction, we'll still do treatment, but there's somewhat of a reduction of just monitoring that behavior. And it's also important that we get supports involved if they're there to help us monitor some of those behaviors. They can be so ingrained that the person doesn't recognize when they are doing it. And a big one is reassurance seeking. So people involved with your patient, you probably want to get them to come to treatment and have a discussion about reassurance seeking and how to respond, because those are going to be the people that notice when the reassurance seeking is happening, but also have to respond differently to reassurance seeking than they're used to. And so that's a really important piece of any, exposure-based treatment, is getting the family involved in changing the environment so that it's not reinforcing the underlying beliefs. Again, ritual reduction is probably the most realistic goal in the beginning. So if we need to, we can do stimulus control. If they really can't resist, in the bathroom when they're getting ready, like getting stuck in the mirror, and that's really, really difficult, we can cover the mirror. We've done that before. And then we can start to open up the mirror slowly so that it's not such an overwhelming stimulus for them and it's really too hard for them to resist getting stuck. We can take tweezers away if they're really where they can't seem to control getting in front of the mirror and starting to pick at their skin. And then just getting rid of magnifying mirrors in general. For a little while, we'll want to reintroduce it. It's not that we're going to take away mirrors forever or take away tweezers forever, but we want to have some control over when they have it so that we can help intervene if they're getting stuck. We write a lot of protocols for people in high urge situations. So like showering for someone who has fears of their hair thinning, we'd want to kind of get an idea of how long they're taking grooming their hair or like washing their hair in the shower and reduce that. If they're, pulling their hair out and counting it, we'll want to try to control that behavior through a protocol. And that they can only, we can only pull, 15 times versus 30 times, and they'll pull their hair and see how much hair comes out. Then we have postponing rituals. So if in situations where you're like, I really don't know if I can resist this, how long can you wait until you engage in the behavior? And then even when you get there, how much longer can you wait? Can you give it more time before you actually engage in that behavior? And then competing responses for physical rituals. Knowing that looking at your face in the mirror is going to produce that urge to, touch your hair, or looking at your hair in the mirror, or grooming in the mirror is going to produce the urge to like touch your hair and see how thin it is. Can you practice some sort of competing response while using the mirror when you get that urge? So if you're brushing your hair and you feel the urge to grab your hair, can you put the brush down and hold your hands together for at least a minute, just to see if you give yourself time for that urge to subside? Exposures are going to be gradual, repeated, and prolonged. How we start is creating a hierarchy of different situations, different triggers, to see how difficult each one of those are predicted to be. And then we start with something that's challenging yet manageable. And again, with ritual prevention. So we always have to highlight that. How hard would it be for you to, groom your hair in the morning and resist completely touching your hair to see how thin it is? I always like to put that part in there so we know that it comes with ritual prevention. It's not just doing it, it's also doing it with ritual prevention. And we want people to do exposures multiple times. So how hard would it be for you to go to the mailbox without a baseball cap on? And, we'll have you do that course, 5 times a day to see, one, what the peak anxiety was and how long it took for that to reduce. We want people to, as best they can, some situations this isn't as easy, stay in the situation long enough so you can give your anxiety the opportunity to reduce. So if you say, okay, I can go to the mailbox without my hat on, but you sprint there and sprint back, you're really not giving yourself the opportunity to have your anxiety reduce in that situation. So we'd want you to do it slowly, maybe hang out by the mailbox for a little bit and then come back inside slowly and see if over the course of that event, did your anxiety reduce? A note here that we'll talk about is when you're doing an exposure, the primary emotion you should be experiencing is anxiety. So I think of it as a pie. So if my emotions, will equal a pie, primarily in an exposure, I should be experiencing anxiety or some form of it, overwhelmed, things like that. You might feel a little bit like different slivers of that pie might be other emotions, like a little bit of shame, a little bit of guilt, maybe a little bit of frustration or irritability, but overall that pie should be anxiety. If you are starting to feel like getting pieces of that pie be more and more different unpleasant emotions, exposures aren't as recommended in those moments, especially if that distress that you're feeling, which I think of as like the pie with equal slivers of a lot of different unpleasant emotions, that distress might lead to unsafe behaviors, whatever that might be. If it's suicidal concerns, if it's, using substances, if it's, getting angry and lashing out at people, we don't really want to put you in those situations. We would want you to try using skills for those, because anxiety, when you're doing exposure, should be the primary emotion, because that's the one that has the highest likelihood of habituating over time. So when looking at mental filter concerns, there are two things we'll do here to address these concerns. One is for the self-defeating interpretations, we'll do thought challenging. And for that over-focusing and that selective attention, we'll practice perceptual retraining. So for thought challenging, we want to say up front that it's not the situation that's upsetting, it's the interpretation of the situation that's upsetting, because all of us can experience a situation and have very different interpretations of it, and thus very different emotional reactions to that situation. And our goal is for the person to think flexibly, not to find the source of truth or to make it a good thought or feel, 100% happy. It's, can you entertain that there's more than one way to look at this situation? And when you do that, do you feel less of the emotion that's very upsetting, and perhaps it's not as intense for you? When we're doing thought challenging, we'll identify a very specific situation that led to some sort of avoidance, and is there a potential in that situation for there to be more than one interpretation? And there's a few ways to think about this or to ask patients questions about this. What was running through your head? How did you feel? Is it possible that this is one of many interpretations of this event? And if it is, why don't we try to figure out some of those other interpretations? I'm not necessarily asking for evidence for or against. I'm just saying, can we think about this in more than one perspective? Is this it's that there's the way that you're viewing it, but could, someone you love view this differently? Do you think I might see it differently? And what are we thinking in those events? And then when they're experiencing unpleasant emotions, that's a good indicator that there's some sort of problematic interpretation happening. I'm not going to go through each of these. I put these in here for everybody to have. We're probably all familiar with very basic common distortions. And then there are some ways how someone with BDD might be engaging in this distortion. We're not just trying to get someone to think positively when we're doing thought challenging, and we're not trying to replace bad thoughts with good thoughts. We're trying to think flexibly and test our theory. And I think of two ways of going about this. One is your thought valid? What is the evidence for or against it? The other is your thought useful or helpful? I'm someone who will more likely go for useful and helpful over valid, especially for someone, and we'll talk about this on the next slide, who's lacking a lot of insight. All of these things could be true, and I don't really necessarily want to argue whether or not they're true, but is it helpful for you to think this way? Is it leading you to live your life in the way that you want to, having these thoughts, or does having these thoughts prevent you from doing things that you want to do? So when you're doing cognitive restructuring, where to start? You don't want to really start with the biggest concern, especially for someone with BDD. There are, kind of already up for the challenge of defending the idea that they are flawed in a big way, and they've done it a lot. So you don't really want to start there. You also don't, feelings are not thought challenging material, because people are allowed to feel whatever way they want to. One caveat is, like, if you're using your feelings to justify the way that you're reacting, that's emotional reasoning or your interpretation, but a feeling in and of itself is a feeling, and anybody's allowed to have whatever feeling they have. You do want to start on thoughts that have outcomes. So if you look at these two examples, they will all think my nose is hideous versus my nose is hideous and I hate it. I'm gonna thought challenge, I'm more likely to thought challenge the first one. I'm not gonna usually thought challenge the second one, because that's their feeling. And someone with BDD, they again have like a lot of evidence for why they believe this. And you're probably not going to get very far thought challenging the latter. And then you may want to start with a hierarchy of negative thoughts and start at one that's easier for someone to challenge versus something that is a delusion. So I say here, delusions are not amenable to thought challenging. And I put the caveat of, like, at least at first, and it's really not the delusion you're challenging, it's the outcome that you're challenging when you're approaching these for someone with BDD. Typically, someone who's coming in for treatment, there is at least a sliver of doubt that what they're seeing in the mirror is accurate, and they might be able to recognize that their response is excessive. But usually you're not wanting to start with like the hot button issue, because that's likely someone's not going to be very movable on that position, especially at first in treatment. But you can talk about the distress that their views cause of, my nose is hideous and I hate it. You can talk about the suffering they feel from that. And I might want to know conclusions from that, like what sort of things are you not doing because of your belief about your nose? And then these are some questions you can ask to elicit some responses from patients when you're assessing some of those thoughts. Then we have behavioral experiments, which I call them exposures plus precise predictions. And a lot of times when you're doing exposures, you are assessing, like, what do you think is going to happen? And then afterwards, what did you learn? That's a good exposure as a provider. But behavioral experiments are more so testing like that belief underlying all of this more explicitly. And with these, you want to do the exposure, but be very precise about what the person thinks is going to happen. So versus people will look at me is a very broad, of course, I think it's high likelihood that someone's going to look at you. We look at people all the time when we're out and about, versus 75% of people I meet on the street will look at me with disgust and horror. And how do you know someone's experiencing disgust and horror? While in the store, 80% of people will move away from me when they're within 8 feet and within the first 5 seconds. These can be hard for people who are of low insight because they typically aren't able to accurately assess what people are doing. They're overly focused on the things that reinforce their belief that they're look terrible or ugly. And then also we want to ensure that the patient is acting naturally in public and not, if they're looking around very intensely at people, they might get some odd looks in response. If they're staring people down to assess their face completely, whether or not it looks like they're disgusted or in horror, they might get some sort of odd response if someone looks up and suddenly they see someone staring very intensely at them. So doing some of these with your patients is important, just to assess whether or not they're kind of creating the situation. Before they do the exposure, what is the situation? What is it about the situation that's going to cause you anxiety specifically? What rituals do you need to watch out for? And what are your negative predictions, being very specific? And then post-exposure, we want to, CBT is a learning model. We want to really highlight what the person learned in the exposure, what happened, and what did you experience? And did what you predict come true? And was it, even if it did, because they will, people will look at you, maybe not 80% of people looking in horror and disgust, but was it that bad to have someone look at you? And then what did you learn from that experience? And then the perceptual retraining. The goal here is we're addressing that ritualistic mirror gazing and those preoccupations getting stuck in reflective surfaces. And we want to use a mirror more functionally and see our appearance as a whole versus focusing in on the things that bother us. And we want to, the way we go about this is being non-judgmental. So we're trying to be as objective as possible when looking in the mirror versus that, barrage of self-defeating thoughts that come in. We're trying to correct them and be objective with what we're seeing. And we're kind of going through our whole body and not fixating on the hot spot. When you have to practice this with your patients a lot at first, and maybe throughout, because they do tend to get very stuck if it's their chin and they start from head to toe, they're going to move quickly, get here, and they might try to spend more time in this area. And then you'll want to encourage them to keep moving. And then they shouldn't be spending an excessive amount of time looking in the mirror, 5 to 10 minutes. This isn't an exposure. It's getting them to practice looking in the mirror holistically and using it functionally. In ways to address this, some patients, that they're really going to struggle with their whole body, seeing their whole body in a mirror. So you could concentrate, head to shoulders first, and then shoulders to knees, knees to toes, and then try to combine it all together. You can work with lighting. So, doing a whole body in dim lighting versus your whole body in a ring light. And then working with, how close you are to the mirror. There are different ways to kind of change the context of the mirror perceptual retraining to make it more or less difficult for a patient. And so really it's kind of meeting them where they're at and seeing how you can do it. But again, you want them in a situation that they can go through and be non-judgmental and not get stuck on a piece of their body. We've talked about this a little bit, that if someone's experiencing distress, what I think of as the pie being equal slivers of a lot of unpleasant emotions, we don't really want to put them in exposure situations because it's a high likelihood that it'll lead to unsafe behavior in those situations. And we'd want to work on emotion regulation and distress tolerance. And we might need to do that first before we can, proceed into the other areas of the treatment. And when we're managing distress, some things you can use our distress protocols, like what levels of distress do you experience and how can we work on skills to address each area. With BDD, we don't aim for overcorrection just because there is the concern with suicidality and those other unpleasant emotions that come up. We're kind of aiming for being more functional. There, case by case, you might have someone who's able to overcorrect some, but really that's not encouraged from a BDD framework. And then for relapse prevention, we want to acknowledge that the expectation of like being better and completely staying better and never having any sort of lapses in symptoms or relapses is unlikely. Success is a very windy path. So we want to plan for when that happens. And also something to consider is someone who's, done very well in treatment. They might have a lot more time on their hands because they've been mirror gazing and stuck in services and grooming and avoiding for a very long time. So you might want to plan in some of what to do with that extra time, some behavioral activation.
All right, thank you. So let's see, I know we're running short on time, so I'm going to go through this section pretty quickly. So one important point to keep in mind is that there are only 2 effective known treatments for BDD. One is cognitive behavioral therapy that is specifically tailored to BDD that Dr. Bailey just discussed, and the other is medication treatment, pharmacotherapy. And within the armamentarium of pharmacotherapy, there unfortunately is not a huge amount of data. But to summarize it, let's say what we'd say is that the medication treatment of BDD is much more similar to that of OCD, however, with much less data. So there are only 3 placebo-controlled trials. Clomipramine, which is a strong serotonin reuptake inhibitor, but it's also a tricyclic antidepressant. And it's the only one of the tricyclics that is a very strong serotonin reuptake inhibitor, was more effective than disipramine, which is a norepinephrine reuptake inhibitor. Then studies of the more typical SSRIs have been pretty effective. Fluoxetine and escitalopram are better than placebo. And then there have been open trials of a number of other ones: fluvoxamine, escitalopram, citalopram, and the SNRI venlafaxine XR have all been found to be effective in fairly rigorously done open trials. So a reasonable level of evidence, but not as good as the the very large scale double-blind placebo-controlled randomized clinical trials. One important thing to know is that just as with OCD, a high dose of these medications and a long duration of treatment at the high dose is required. So a lot of times patients with either disorder will come in and say, oh, I've tried all those medications, none of them worked. And what you find is that they didn't have adequate trials. Let's say they had 20 or 30 milligrams of fluoxetine. That wasn't going to work. What they really need is more like 60 or 80. They've had 100 milligrams of sertraline or Zoloft, and again, not nearly high enough. Next slide. Or their trials were too short. So their doctor didn't see improvements in the first 3-4 weeks, and so they stopped and switched to another one. And so the usual daily doses of these medications are considerably higher than what is required for treatment of major depression or for other anxiety disorders. The OC spectrum disorders such as OCD and BDD do require these higher doses. And sometimes we go to very high doses that are well above the FDA guidelines for particularly refractory patients who are still tolerating those doses. So for citalopram or Celexa, its dose range is usually around 40 milligrams a day. Once we're higher than that, then there's a risk of cardiac conduction problem called QTc prolongation, so that the guidelines suggest that we shouldn't go over 40 or 60. That being said, if you actually look at true surveillance studies, there is actually a pretty low rate of QTc prolongation. So that concern has been massively overblown. Escitalopram or Lexapro, fluoxetine or Prozac, fluvoxamine or Luvox, paroxetine or Paxil, sertraline or Zoloft, and clomipramine or Anafranil. All of these are either more selective serotonin reuptake inhibitors or the tricyclic medication that is also a strong serotonin reuptake inhibitors. And you'll see the usual daily doses are about 2 to 3 times as high as would normally be indicated for depression or general anxiety or panic disorder. Well, so what sort of outcomes should we expect? If patients receive a full trial, if they get at least 10 to 12 weeks at a full dose of an SRI medication, more than half, maybe 50 to 70% of patients will respond. And that degree of response, usually the criterion is at least a 30% reduction on the BDD-YBOX scale, plus much improved or very much improved on the clinical global impressions or CGI scale. And so, the majority of patients will have that response as compared to only around a quarter or less, a smaller percentage responding to placebo. The average degree of symptom reduction is somewhere around 40%. And it could be anywhere from 35 to 40%. And there's a big range. Many people will be partial responders. They'll have 20, 25, 30% improvement in their symptoms. Very few patients will be super, super robust responders where, you get 60, 70, 80% reduction in symptoms simply from medication alone. So most often what you're going to see, just as with OCD, is partial improvement. Usually quite significant, so they can say, yep, it's working, but it's not taking their symptoms fully away. What also improves are the coexisting or comorbid depressive and anxiety disorders. Insight also improves. And in fact, SRI medications are equally effective for delusional and non-delusional BDD. Usually the delusional patients will have an improvement in insight so that they're no longer delusional after the full trial of SRI medications. Overall functioning also improves. Social functioning, occupational functioning, academic functioning, and so on. Next slide. What about augmentation studies? So if we have lots of patients who get maybe a partial response, we still are probably getting, 40 or 50% of patients who are non-responders, and then another chunk who are partial responders. What do we do? Well, the most effective and important augmentation strategy is CBT, right? not any of those medications. The combination of medications and CBT is by far the most effective treatment for most patients, especially because most patients don't have a single disorder, they have multiple disorders, right? Comorbidity is the rule, not the exception. And this is true across almost all different psychiatric disorders. The combination of a directed, targeted, focused psychotherapy, such as CBT for BDD or exposure and response prevention for OCD, plus medication is more effective than either treatment by itself. And especially for more severely ill patients, especially for more highly comorbid and complex patients. There's been a little bit of study of augmentation strategies. So adding on clomipramine at a low dose on top of a more selective serotonin reuptake inhibitor can be somewhat effective. This is a well-known strategy in OCD. We just don't have as much data in BDD. Buspirone, there was one open case series of just 13 patients, but close to half of them did improve when buspirone at a fairly high dose, an average dose of around 45 milligrams a day total, was added on. Lithium maybe, but there's only case reports. What we usually go to as augmenters are atypical or second generation antipsychotics. These have been found to have by far the best track record in treatment refractory OCD. In OCD, there are many large scale placebo controlled trials that are well done that show pretty conclusively that virtually all of the atypical antipsychotics are effective for a good subgroup, anywhere from a third to a half of people who have treatment refractory OCD that hasn't responded well enough to serotonin reuptake inhibitors. In BDD, unfortunately, there's only one control trial, and that was of an older first generation antipsychotic, Pimozide, that was no better than placebo. Case reports on olanzapine were mixed, but clinical experience, when we get together and have meetings of clinicians who see a lot of BDD patients, we all end up talking about how we use, aripiprazole, sometimes risperidone, sometimes ziprasidone, and we tend to get a pretty good response, similar to what we're seeing with refractory OCD. These medications are also highly effective for treatment-resistant depression. And of course, many BDD patients have treatment-resistant depression. So there are multiple reasons why this particular class of augmentation medications is effective. More recently, there have been studies of anticonvulsants such as levetiracetam or Keppra. Only one open trial looked pretty good, but other than that, no extra data. Other antidepressants of other classes, such as Wellbutrin, other tricyclic antidepressants, mirtazapine, other mood stabilizers like lithium by itself or lamotrigine, antipsychotics given by themselves, or even ECT, are not effective for the core symptoms of BDD. They may be very effective for coexisting depression, but if that depression is primarily secondary to the BDD, it won't usually respond. All right, so let's get into the intensive multimodal treatment of severe BDD, such as is done in intensive outpatient settings, partial hospitalization settings, residential or inpatient settings.
So there are different levels of care. I put on here kind of what the average length of time is each day. One important difference between residential and inpatient. Residential is a voluntary program. It's, for us, it's an unlocked unit. Patient has access to outside and can leave. An inpatient unit is a locked unit, and it's usually acute crisis, imminent danger concerns. And in a residential setting, you can have safety concerns, but there's the ability to discuss and address them and follow protocols related to maintaining safety on that unit. And then there's also medication management that can go into that level of care too, that can be observed, daily. So when we're thinking of who needs higher levels of care, how I see it, and there's a lot of different factors, such as, have they had a lot of trials of outpatient treatments and attempts that were unsuccessful? Have they tried other levels of care? And so they're in IOP, do you move them up to PHP if they're not successful? But a lot of times when they're not successful in those other levels of care, it's usually they're able to engage, but once they leave programming, they struggle. And that would tell me that, in the evenings or when they're outside of having someone there coaching them, it's really difficult for them to follow through particularly with the ritual prevention piece. We would want that person to seek a higher level of care. And residential is a 24/7. The clinical staff aren't there 24/7, but there are staff there to help coach a person through disengaging from rituals when in tough situations. Or if they're really struggling to just follow through with exposures outside of programming, that would suggest they need a higher level of care too. If they're not able to make it to programming, that's a huge factor. If a person is engaged in excessive grooming and they can't get out of the house in time to be on time to an IOP or a PHP, that would suggest that they need a higher level of care. The difference between residential and inpatient is safety risk and crisis. So someone who is really struggling with suicidality and there's concern of imminent danger, that's when we would seek inpatient services to keep them safe. But that's not to say that someone might have a course of that over their time in residential where they have a span where they become unsafe and at risk of hurting themselves more so than can be managed in an unlocked unit. They'll have to go to inpatient, they will stabilize and then can return. And then the more complex the case gets, the more likely that they would need a higher level of care as well. And with BDD, that's fairly often. Like we said, there's comorbidity is the rule rather than the exception. So if someone's able to engage in treatment and engage outside of the treatment setting and has relatively low risk, usually they can be managed in an outpatient setting. As those two variables change, the higher likelihood that it is that they would need a higher level of care. What's important about the multimodal treatment for me, a big piece of it that I think is kind of like a non-specific factor is the structure. A lot of times people who are experiencing intense depression have been isolated, haven't engaged regularly with important things in their life. They've gone off schedule, and being in a higher level of care offers that schedule just in and of itself. So following that schedule is really important. I think that does a lot for people, is just to get back into, waking up at a certain time, taking your meds at a certain time, going to group, having an expectation of showing up at certain places and meeting with people. That's a really important piece. But the other really big piece is the specialized care. And I don't want to say the schedule is more important than the specialized care, but the specialized care is there. You have the interdisciplinary team that is addressing the concerns from different angles and working collaboratively to address the psychological issue that's bringing someone to that level of care. And the other part of being in a different atmosphere is that you experience in a different environment. So something like reassurance seeking, the world is built typically to be nice and thoughtful, but when it comes to reassurance seeking, that can be problematic for someone. So when you go into, an IOP, a PHP, or a residential, the people on staff there are specifically trained to respond differently than other people would in your external environment. And that difference is, not providing reassurance to someone or responding in a way that encourages that person to think about what they, I'm sorry, there's a lot of people walking by my window because I think they're doing like a active shooter training on site, so I'm distracted. We want to give them a different experience than they would in their home environment. And a big piece of this is being incorporating family or loved ones that could be providing that reassurance at home to also change that environment as well. And in those settings, there's also a lot more oversight of medication changes that can happen more quickly than they typically can in an outpatient setting, because you're being monitored daily for any effects of medication. A little bit here on willingness versus willfulness. A lot of times a willfulness can come from the home environment not supporting change. So if there's not a lot of reasons for the person to change, the parents or loved ones or anybody in the environment is very willing to provide cosmetic surgery and very willing to engage in that discussion and more than happy to provide finances for that, then there's probably not a lot of push to change that behavior because it's going to be solved in the way that they desire to change it versus a different way. And sometimes it's helpful to sit with open hands, I call it, of, is this working? Is this working for you? Are you living the life you want to live? A phrase I stole from one of our therapists in residential was, can we agree that you're unhappy? Usually the patient can agree that they're not happy with the way things are going for them. And then can we also talk about, are there things that we could start changing that could make you feel better, such as like the behaviors that you're engaging in excessively? Can we start there? Or can we start to address the amount of distress that you're experiencing through distress tolerance and emotion regulation? And then we just want to acknowledge that there are differences seen for BDD symptoms among different populations. So I think on the slides that you might have, it says Caucasian and versus Caucasian. So I apologize for that. But there were more BDD symptoms among Caucasian and Latina women compared to Black or African American women. And then sexual minorities tend to endorse more BDD symptoms than heterosexual participants. And then access to care can be limited for some. In one study there, the Latina population endorsed more barriers in the following categories. So just logistics, financial barriers to treatment, insurance, shame, stigma, and discrimination when it came to accessing care than others. And then in the same study, Asian participants had endorsed fewer barriers, but that also there was some recommendation that that could be just because the a perception for Asian participants that, you know, they have a lot of more internal resources. And then a lot of people are not receiving CBT. They're seeking treatment from non-mental health providers. They're going to dermatologists, they're going to plastic surgeons, and treatment credibility, really building the hopefulness in treatment and the credibility of treatment up front can moderate some of the success of CBT for BDD.
Great, thank you so much. Now it's going to be some time to answer some Q&A. If you have a question, please use the Q&A button, not the chat feature. We will try to get to as many questions as possible. There is some really great questions in the chat. So if we do not get to your question that was submitted, we were going to email some of these answers afterwards of our webinar today and follow up with you. So let's go ahead and get started with our first question. When a patient has when a patient with BDD has zero insight, what is the treatment course then? Dr. Saxena?
Yeah, I think Dr. Bailey alluded to this a little bit, but I think you still apply the same components of treatment, but they're modified. And certain aspects may be more emphasized than others. I think the first thing to do, as we talked about, is to empathize with suffering. And I like to center on the patient's lived experience, to not only talk about their what they're experiencing, the visual perception and their distortion, but to also find out about what their experience has shown them about what other people think, right? And we can acknowledge their beliefs and perceptions, and as Dr. Bailey said, don't argue with their beliefs, but you can start explaining why they have that belief in the first place, right? And where that belief comes from. And why is it that other people with BDD may have similar beliefs about themselves, even though nobody else thinks that they have that problem either. So, and that's why I mentioned that having them read about other people with BDD, having them meet other people with BDD, right? If two people with BDD each believe that they're ugly, but they can clearly see that they don't think the other person is ugly, then it starts softening up that belief. So we focus on distress and empathy. We focus on functioning. We may not necessarily go jumping into exposures at the beginning, because the patients will often refuse those exposures if they really believe that something terrible is going to happen. And instead, we work on the beliefs in a variety of different ways, motivational ways, providing psychoeducation, right? If you explain that the reason that people are perceiving themselves as deformed, repulsive, ugly, flawed is because of a problem in their neural pathways for visual perception of themselves, and how those differ from the pathways that we have for perception of other things, right? So people with BDD can see other people just fine. They can have no abnormalities in the rest of their color and depth perception and shape perception, but there are particular neural pathways that are mediating the perception of oneself, and they're heavily influenced by the limbic system. by areas that are involved in emotional processing. And this creates the overlay between negative self-esteem, negative emotions about one's appearance, and the actual mental representation of their appearance that they're perceiving. Once you start explaining that, it starts cutting into, oh yeah, I just must be ugly, right? And so there's a variety of ways of getting at delusionality and poor insight, which is obviously very common in BDD, from the edges. But I think that the start has to be with education and empathy.
I agree. And I also think with that education too, in some of that, I call it seed planting. You have to plant a lot of seeds. So it's not just like a one-time conversation. You'll have to like have that conversation over and over again. And I joke sometimes it's like you have that conversation 10 or 15 times and they'll come into session and be like, well, my grandma was talking to me the other day and she said, da da da. And you're like, yeah, good. Grandma's right, you know? So it's just about like putting that seed there to grow, and then it could be harvested at a later of time, but for treatment, that can feel difficult, especially for people who are CBT oriented and they're really like action oriented of like, let's go, let's get exposure started, let's start band tracking. I know that we're like that in residential, we want to move very quickly. And so it can be harder for us to slow down and take that time to have those conversations and really focus in on like providing that psychoeducation. And you know, we wouldn't diagnose you with BDD if we didn't think there was a reason to, right? And keep going over that, the criteria with them and, you know, the ways in which they meet that criteria.
Great. Another question is really working with families. How can you talk more about working with families and how they can respond to the reassurance-seeking behavior more helpfully?
I think families are very well intentioned. They really want their, and I'll say the child, you know, they want their, and a lot of times adult child to feel happy and feel good about themselves. And so I think it's a very, you know, parent, I feel that pull of just like lecturing and coaching through that. And it's a totally different response to not provide that lecturing and coaching and to have them, to have them have a discussion with them and like say, you know, I want you to be happy, and a way for you to be happy is for me not to answer that question. And you know, I love you. I want to see that you be successful. And I can see that this is really hard for you, and validating emotions. It's usually not the first thing a parent does typically. So there's a lot of coaching on how to respond and having the patient involved in that. And like, because you don't want to say something that's going to not upset them, but be annoying to them. Like if they're going to hear the same phrase over of like, well, what do you think? They're going to have a hard time with that. So, you know, having them involved in like, what would you like for your loved one, your parent to say when you are struggling with this outside of a time when they're really stuck? Don't have that conversation when they're really high emotion. What could be helpful for you to hear that's not going to reinforce your perception that you're flawed in some way. And so I think having them as a part of that conversation can be helpful versus like playing the expert and saying like, oh, you should say this and this and this and this way, because that's what the book says, right?
Yeah, family accommodation overall is one thing that interferes with the effectiveness of cognitive behavioral therapy. This has been seen in OCD, but it's also in eating disorders and BDD and anxiety disorders. And so providing education to families about that whole process, that providing reassurance, while it feels like the intuitively, right thing to do, is actually just reinforcing the doubt and fear. And so then working with them in the family sessions to gradually reduce the degree of reassurance seeking. You can't cut it off abruptly. The person might, start having more panic attacks. But you can gradually set up a behavioral plan for the family members, just as you do for the patient with the disorder, to have a gradual tapering off of that reassurance and to get to the goal of not providing reassurance, so that the person will have an opportunity to test out their beliefs and obtain evidence to the contrary, and not keep reinforcing the fear and the doubt and the need to get the doubt answered by other people rather than themselves.
Great. Well, unfortunately, that's all we have time for today. We have so many great questions. So again, if we did not get to your question, please feel free to email email your questions to the webinar at rogersvh.org, and we will follow up with you. Many thanks to Dr. Bailey today and Dr. Saxena for taking the time to share all their valuable insights. Before we conclude, I'd like to ask our partners to share a few additional resources on this topic with all of our participants. Thank you again. This wraps it up for our CE webinar of today. For those of you who met the required time commitments, you will be eligible for this continuing education credits. Within the next 30 minutes, you will receive an email with a link, personal dashboard on cego.com, where you'll be able to access the PDF today, the PowerPoint presentation and slide as a handout with a complete list of references. And those of you who met the time requirement to qualify for the CE credits, you will need to complete an evaluation and download your CE certificate for this event today. If you have any questions about a follow-up email, please contact support@ce-go.com. And again, on behalf of Rogers Behavioral Health, we look forward to your partnership and partnering with you and all of your patients. Thank you so much for taking the time today to join this very important topic and webinar. Thank you so much.